handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day, everyone. Welcome to part 1 of the organ system integration for CVS. So for this session, we will be going back to the basic sciences. We will be tackling some basic concepts, and hopefully the things that you will learn for this session, you will be able to use them in order to understand better the succeeding concepts. As an overview, we will be looking into some basic concepts in hemodynamics, electrophysiology, and of course, we need to learn to correlate this clinically. And what better way to do that than to practice reading ECG strips? So dapat marunong tayo lahat magbasa ng ECG. And of course, lastly, we'll also take a look into the cardiac cycle. So for anatomy and histology, we will look at the gross anatomy of the heart, the cardiac conduction system, the coronary arteries, as well as the histology of the heart and the blood vessels. So for this part, I specifically picked topics that I think are more important clinically. For biochemistry, there's not much specific topic, so to speak. So we will just look into what's peculiar about the metabolism of the heart. And of course, a lot of cardiovascular diseases or cardiovascular conditions are related to lipids, right? So let's quickly look over it as well. So to kickstart our discussion, let's start with anatomy. So here you can see how the heart is associated with the surrounding structures. You can see how it's lying between the lungs, within the thorax, and below you see that behind it you have the esophagus, the aorta, the azygos veins. No? But the thorax is actually quite a big space. So where exactly is the heart? No? So the heart is actually in a space called the mediastinum. But even the mediastinum would have specific compartments. So the mediastinum is actually further subdivided into several compartments. So you have a superior mediastinum over here and an inferior mediastinum over here. It's actually quite a big space. So what would delineate the superior and the inferior mediastinum would be an imaginary line, no? And that line is something that you draw from the sternal angle of Louis all the way to the T4 and T5 intervertebral space. Okay, so ito siya. Okay, so this would be the delineation between the superior and the inferior mediastinum. But the inferior mediastinum, as you can see here, is quite a big space, and it's actually further subdivided into the anterior mediastinum, the middle mediastinum, and the posterior mediastinum. So as you can see in this image, obviously the heart is found in the middle mediastinum. Okay? So suffice to know, ito yung pinaka-concern natin, no? Nasa middle mediastinum yung heart. This is quite important when we're dealing with other conditions, like say for example, masses, malignancies, no? Bakit? Because some masses, some form of malignancies tend to be more common on certain compartments compared to the others. So how will we describe the borders of the heart? So the apex of the heart is actually formed by the left ventricle, and it lies within the 5th intercostal space, mid-clavicular. So this one is approximately around 9 centimeters when you draw a line from the midline, and then you measure it, it's around 9 centimeters. So the base of the heart is basically the posterior aspect. Okay, so wag magkakamali. No? Pag sinabi nating base, it's not the inferior aspect, but rather yung the posterior aspect for which it rests. No? And it's formed primarily by the left atrium and partly by the RA. The right border of the heart is comprised of the right atrium and partly the SVC, IVC. While lastly, for the left border of the heart, you have the left ventricle. In terms of auscultation, so where do we put our stethoscopes in order to appreciate the murmurs coming from the different valves? Okay, so actually, the anatomic location would be quite different from the auscultation area. Okay, so here in this image, you can see mga red areas dito. Ayan, no? Itong mga red areas na to, they would actually tell you the actual anatomic location of the valves. Pero, pag sinabi nating auscultation na site, no, it's actually quite different from the actual area, no? So, what would be our landmarks? So, when we want to appreciate some murmurs coming from the aortic valve, so to speak, we want to place our stethoscopes over the second intercostal space, right parasternal area. This one, okay? Paano naman kung gusto natin marinig pulmonic valve, no? So you place your stethoscopes in the second intercostal space, left parasternal naman. So basically just opposite the auscultation area for the aortic valve. And below, no, at the left lower sternal border, you have the area for the tricuspid valve. No, this one is more variable as compared to the others. And then lastly, if you want to appreciate the mitral valve, you want to place your stethoscope over the fifth intercostal space mid-clavicular. Okay, so dito siya. Let's try to correlate it clinically. So let's look at the chest x-ray. Yung chest x-ray, guys, no, it doesn't just tell us pulmonary pathologies, pneumonia, PTB, no? It's actually quite suggestive of a lot of cardiac conditions. Okay, minsan isang tingin mo pa lang sa x-ray, alam mo na, uy, ang laki-laki ng puso. Uy, tubular yung heart, so baka COPD or obstructive lung disease. Okay? But how can we be more objective about it? Paano ba natin objectively masasabi that the heart is enlarged? Have you heard of the CTR or the cardiothoracic ratio? So basically, i-measure natin, no, itong area occupied by the heart over the entire thorax. And usually, the cutoff value for that is around 0.55. Okay, if the value is above 0.55, we know that for a fact that the heart is enlarged. Although sometimes grossly, isang tingin mo pa lang, alam mo na malaki-malaki talaga yung puso, right? But careful, make sure that you are looking at a PA view. Okay, because what happens in an AP view, kung example, supine ng patient or ang patient is sitting, no? Usually kapag sitting, ang hirap naman mag-PA doon, di ba? So if the patient is unable to stand, no, hindi ambulatory, most likely AP view yon, and an AP view will magnify the heart. Okay? So it's a little bit more tricky, it's a little bit more difficult to say that the heart is enlarged kung AP view yung pinag-uusapan. Okay, anyway, going back. So what are the structures that we can appreciate in a simple chest x-ray? Over the left border, here you can see parang may nakausli doon, no? So that's actually representative of the aorta. Okay, so that's the aortic knob, and sometimes you will be able to see na malaki siya, or minsan parang may puti sa loob na outlining that. So we can say for a fact na baka atheromatous yung aorta, pag ganun, no? Below that, you have the left pulmonary artery, the area for the pulmonary artery, and below it, you have the left atrium, and then you have the left ventricle. You know for a fact, again, that the apex is comprised, most of it would be the LV, right? So if you have LVH, left ventricular hypertrophy, as a result of a lot of conditions, no? In example, hypertension, di ba? So you will have displacement of the apex. So makikita mo, hindi na siya nandito, no, sa approximately mid-clavicular. You can see na baka nandito na siya or nandito na siya sa edge, no? On the right-hand side naman, ano naman yung mga ma-appreciate natin? SVC. You have the right atrium and then the inferior vena cava. Okay? So, for example, lumaki yung cardiac silhouette on this side. No? So, you know for a fact na yung enlargement, baka right-sided siya, baka right atrial enlargement siya. Okay? So, yun yung mga basic things that you're going to look for in a chest x-ray. Okay, what if ganito naman ang nakita natin sa chest x-ray? This is a huge, huge heart, pero hindi lang siya basta-bastang malaki, no? Bakit kaya siya ganito? This shape is described as a water bottle appearance. Okay, and alam ko, narinig nyo na yan, no? Pag sinabi natin water bottle appearance, this is suggestive of pericardial effusion. Okay, and in some cases, pwedeng in cardiac tamponade na siya. Okay, so if you have a patient with this kind of chest x-ray, it's very, very prudent that you do a 2D echo or a point of care ultrasound to see if there is really pericardial effusion. Okay? Because what if malaking-malaking puso nga lang naman talaga siya? Because it happens. No, minsan malaki lang talaga yung puso pero wala naman palang effusion. Okay? So clinically, you need to correlate this as well. You look for signs, no? You auscultate, muffled heart sounds ba? Nag-hypotension na ba yung patient ko, no? Meron ba tayong pulsus paradoxus? Or distended ba yung neck veins ng patients natin? So you need to correlate it clinically as well. to be able to appreciate it better, no, correlate lang tayo sa ultrasound findings or echo findings to be more specific. So this is a heart on the apical four-chamber view. So ano ba yung mga structures na nakikita natin on an apical four-chamber view? So punta muna tayo dito. This one over here, this is the right atrium. Above it would be the right ventricle. So guys, para lang siyang pusong binaliktad. On this side, you have the left ventricle, and on this side, you have the left atrium. Surrounding it, you have a black area. Ano kaya yung maitim na yun, guys? No? Anechoic, meaning the sound does not travel through that area. So ano kaya yun? So this is actually fluid or effusion, no? Specifically pericardial effusion. Okay? So how can you say that this is pericardial tamponade? Okay, echo signs of tamponade. No? So what are the things that you're going to look for? Ayan, so you can have RA collapse. Okay, you can have RV collapse. The heart could be swinging. Okay? So, those are the things na hahanapin natin. Okay, so let's try to take a look at the video. There you go. So, you can see how the wall of the RA and the RV is collapsing. Nakita niyo yan? Okay, so there's underfilling of the LV and the heart is actually swinging. Okay, so echocardiographically, those are signs of tamponade. Okay, and of course, you see that there is a very, very big space over there. No? It's a large pericardial effusion. So, pag ganun, ingat-ingat na tayo. Okay? So, definitely, you need cardio on board for this patient. So, this is again the apical four-chamber view. So, applying now what you've learned in the previous discussion, where are you supposed to put the probe for you to be able to elicit this four-chamber view? Sabi natin, apical view. So, the apex is expected to be in the fifth intercostal space, mid-clavicular line. That's why if you're going to look at this picture, you can see that the probe is placed just immediately below the nipple. Diba? Kasi alam natin that the nipple is around in the fourth intercostal space. Below that would be the fifth. So, the apex is roughly around that area. So, now we have the parasternal long axis view. So what does this area represent? Ito. So this will be the left atrium. Below this would be the left ventricle. So LALV. In between them, anong valve kaya to? Of course, it would be the mitral valve. Okay, so this one. So from the LV, meron siyang daanan palabas. No? You have the left ventricular outflow tract. Of course, this will now lead to the aorta. So, ano kaya to? LV aorta, ano kaya yung valve dito? So, this would be your aortic valve. Okay? So, a good way for us to be able to, roughly measure if the LA is dilated or if the aortic tract is dilated, no? They should be somehow similar in size. Okay? So, parang ito, makikita natin, mukha naman siyang normal. Okay? This part right here would represent your interventricular septum. And this part over here will just present the right ventricle. Okay? Minsan mahirap makita yung RV, no? In cases na malaking-malaking right side ng heart, no? Mga right-sided na heart failure, RVH for example, you can see it's very prominent. Okay? Meron black part dito, no? Itong bilog na to. This one is actually part of the descending aorta. Okay? So it's not always easily visible. So following now, no? What we've learned earlier, where are we supposed to put the probe if we want to be able to elicit this view, this parasternal long axis view? So, paano siya? It has to be in the left parasternal, no? So, parang pag ganito siya. Okay? So, with your marker of the probe pointing towards the right shoulder. Okay? So, that's how you elicit the plaques view. Okay, so apart from this, there are still a variety of different views, but that's already beyond the scope of our discussion. Okay? So, para lang at least na-appreciate natin, no, yung anatomy, it can still be correlated in your imaging. Okay. So, how about the conducting system of the heart? So, you have, of course, the SA node, you have the AV node, and then you have the bundle of His, separating into the left and to the right bundle branch, and then giving rise to the Purkinje fibers. So, let's start off with the sinoatrial node, or basically the SA node. So this E node is the main pacemaker of the heart. Okay, so it's found in the upper end of the crista terminalis. It's found near the opening of the SVC, located in the right atrium. So you look at this picture so you don't forget. Ito siya, no? Sinoatrial node. You see how it's closely associated with the superior vena cava found in the right atrium. So the SA node is supplied mainly by the sinus node artery, which is actually a branch of the right coronary artery. And you can see the significance of this later on. Okay? How about for the AV node? So the AV node lies within the interatrial septum. Saan yon? So tingnan natin, ito siya. Okay, so there you go. There you have the AV node in the interatrial septum, and it's superior and medial to the opening of the coronary sinuses. Okay, and this one is supplied by the AV nodal artery, which usually also arises from the RCA. So bakit important yun? So if you have conditions affecting the RCA, say for example, it will also affect the pacemakers of the heart, no? The S8 node, the AV node. Okay, kaya some patients who have arrhythmias, no, nung ginagawa natin, we work them up for ischemic heart disease or coronary artery disease, no? Baka after post PCI, no, re-establish natin yung flow sa coronaries, baka ma-regain natin yung activity na SA node, AV node, so we can abolish the arrhythmia. Okay, so that's one of the things that we look for in the workup of patients with arrhythmia. Other pacemakers, you have the AV bundle or the bundle of His, beginning at the AV node, and you know it will run along the membranous part of the interventricular septum, splitting into the right and the left bundle branches, descending into the muscular part, basically, of the IV septum. Okay, and then later on, it will give rise to those Purkinje fibers. So again, for the vascular supply of the conducting system, for the SA node, sabi natin kanina mainly from the RCA, right? 60% from the RCA, but 40% could be from the left circumflex. For the atrioventricular node naman, 90% will be coming from the right coronary arteries, but 10% could be supplied by the left circumflex artery. For the bundle of His, you have mainly supplied by the RCA, but there are contributions from the septal branches of the LAD. And then you have the right bundle branch over here. Okay, so for the right bundle branch, you have the septal branches of the LAD, often with collaterals from the RCA and the left circumflex artery, depending on which one is dominant. Okay, punta naman tayo sa kabila. Left bundle branch naman, this one is supplied mainly by the LAD, but may have collaterals as well. Okay, so yon. So now let's talk about the coronary arteries. The coronary arteries, guys, would arise from the ascending aorta, and they are filled with blood during ventricular diastole, or basically during ventricular relaxation. And why not during ventricular contraction or ventricular systole? Basically, you know that you have only minimal blood flow during systole because of the compression of the arterial branches in the myocardium. Okay, so it's very important that you allow the heart to relax so that you are able to give enough time for the coronary arteries to be perfused with blood. Okay, so in patients who are tachycardic, say for example, ano bang nangyayari kung nagtatachycardia? Which one is affected more? Is it systole or is it diastole? So it's actually the diastole that is affected more. It gets shortened. Okay, so if the diastole becomes shortened because the heart rate goes up and up, what do you think will happen? Of course, the coronary arteries will be poorly perfused. Diba? Kasi hindi natin siya binibigyan ng oras para magkaroon ng filling of blood. And this is also the reason why in patients who are tachycardic, sometimes pwede tayo makakita ng ischemic changes in the cardiac monitor, in the ECG, and we say that it could be rate-related. Okay? And once the tachycardia resolves, pwedeng nawawala din naman yung mga ischemic changes na yon. Okay? So you have here an image showing you the coronary arteries as it arises from the ascending aorta. Okay, so let's start. You have first the left main coronary artery over here. Short lang siya, So the left main coronary artery would give rise to the left anterior descending artery. Yun, yung mahabang pababa. Okay, as the name implies, diba? Anterior descending artery. And the anterior descending artery will give out diagonal branches. Okay, so may mga number yan, D1, D2, ganun. Okay, and apart from the left anterior descending, you have the left circumflex artery as well. Okay, so ito, the one that curves posteriorly. And the left circumflex artery will give rise to the marginal branches. Okay, so ulit, LAD, diagonal. Circumflex, marginal. Okay, at tinatandaan ko na lang yung D, descending, yun yung may diagonal branches. Okay, so on the other side naman, dito sa right cusp natin, it will give rise to the right coronary artery. And the importance of right coronary artery, as we mentioned earlier, is that it gives out branches to supply the pacemakers of the heart. Diba? Yung SA node and even the AV node. No? Meron tayong AV nodal artery. So let's focus first our attention on the right. So here you can see the ascending aorta. And when you cut it open like that, you can see that there are several coronary cusps over here. So on this side, you have the right coronary cusp. In the middle, you have the non-coronary cusp. And on this side, you have the left coronary cusps. And you can see that there are holes there, no? Para may mga butas, those are the coronary ostiums. And you can see, or the coronary ostia rather. So on the right coronary cusp, you have the right coronary artery arising from that. No, yung coronary ostium naman on the left-hand side, you have the left coronary artery. And as the name implies, the one in the middle, it does not have a coronary ostium. Therefore, there is no coronary artery that will arise from this part. Okay, so the right coronary artery, generally, this will supply the RA as well as the RV. And this would give rise to several arteries. As mentioned earlier, yung mga pacemakers natin sa SA nodal artery, the AV nodal artery. And this would also give rise to the marginal artery as well as the posterior descending artery. So now we have the left coronary artery. So this one arises from the left aortic sinus. As you can see in this picture, andito siya, no? So left coronary cusp giving rise to the left coronary artery. This one, compare it to the RCA, it's actually quite short, but it actually is distributed to more of the myocardium. The left coronary artery gives rise to two major arteries. You have the LAD, the left anterior descending, and then you have the LCX, no, yung left circumflex artery natin. So si left anterior descending, it supplies the anterior aspect of the RV, no, you see right ventricle, left ventricle. It's the chief source of blood to the interventricular septum involving the apex. Si circumflex artery naman, this one you see it running in the coronary sulcus, no? So here we have the coronary veins in the anterior and the posterior aspect of the heart. So ito, no, yung sa anterior aspect, here we have the posterior aspect. So here we can see you have the great cardiac vein that would run down across the heart together with the left anterior descending artery. And then may continuation yan, no? You have the great cardiac vein, palikod, andito pa din siya together with the circumflex artery. No? And then it will empty into the coronary sinus over here. Okay, so when we talk about the coronary sinus, this is the largest vein that drains the heart, and it lies along this area which we call the coronary sulcus. Okay, and the coronary sulcus will now separate the atria from the ventricles. What another peculiar thing about the coronary sinus is that it empties into the right atrium, no, between the opening of the IVC and the AV opening. So ito yung sinasabi ko kanina, no? Hanapin natin opening of the coronary sinus. Where is that? Ito. Okay, so you have the opening of the coronary sinus, and as we've mentioned, it's between the opening of the IVC, yung IVC mo, diba? So opening yan, and the AV opening. Okay? So the heart would have several layers. So ito, no? You have the endocardium over here. And then after that, the thickest layer, ito itong puro muscles na yan, no? That's the myocardium. And then after that, you can see there is a very thin yellowish layer over there. That's actually the epicardium, although walang label. No? And then after that, yun pa yung pericardium. Okay? So endocardium is a very thin layer of endothelium and supporting connective tissues. It's actually the layer of the heart that gets in touch with the blood in the lumen of the ventricles and the atria. Pag sinabi nating myocardium as mentioned, ito yung thickest layer, ito yung muscular layer. The epicardium is composed of simple squamous mesothelium supported by a layer of dense fibrocollagenous connective tissue with blood vessels and nerves. Okay, so si epicardium is very closely associated with the visceral layer of the pericardium. Okay, pop quiz. You have here three images, no, showing three types of muscles. So, can you tell me which one among them is the cardiac muscle? Sino sa A, B, or C? Okay, do you have your answer? So, the correct answer here is actually letter B. Okay? So, si letter A, this is actually a skeletal muscle. you can see the striations and you can see that there are multiple nuclei. No? So yun yung characteristic niya, striated, multinucleated. And it's actually a lot similar to the cardiac muscle. Si cardiac muscle, may striation din, no? But the difference here is, look at the nucleus, isa-isa lang. No? Isa-isa lang, so single ang nucleus niya. And usually it's central. The one on the right, single nucleus yan per cell, also central, but it is not striated. So, ano ba si letter C? Letter C is the smooth muscle. Okay, letter B is your cardiac muscle, and letter A is your skeletal muscle. So, cardiac muscles are striated like your skeletal muscles because they have actin and myosin filaments that are arranged in sarcomeres. So, that particular arrangement will give rise to the striations. Okay, they are involuntary, much like, ano ba yung involuntary din? Smooth muscles, right? Lining our internal organs. You have a single central nuclei, much like, again, your smooth muscles, and these cells are often branched and they are tightly connected by specialized junctions. So this would make them different from your smooth muscles because smooth muscles, you know, they are not branched, no? Usually they are just single cells, okay? So if you are able to see intercalated discs, no, I want you to think of cardiac muscles. No? So ito yung medyo mas peculiar for the cardiac muscles. So now let's talk about the arteries. So maraming types of different arteries, and in the body you have arteries of different shapes and sizes. No? So you have elastic arteries. Pag sinabi nating elastic arteries, these are considered to be conducting arteries. Okay, so they are characterized by the presence of a thick tunica media. And when we talk about elastic arteries, think of the big blood vessels. So examples natin dito would be the aorta, the pulmonary arteries, the common carotid, and the subclavian. Okay, yung mga malalaki to. How about the muscular arteries? Muscular arteries are considered to be distributing arteries. They have prominent internal elastic lamina and an external elastic lamina. And they also play a role in regulating blood pressure by contracting and relaxing the smooth muscle in their tunica media. So here we have a microscopic view of an elastic artery side by side with a muscular artery. So ano ba yung mga key or major differences that you can see? Right off the bat, you can see in the elastic arteries, no, napakakapal ng tunica media niya. And ano yung mga swirly na structures na, yung parang spiral shape na structure. Those are actually elastic fibers. No? And as the name implies, elastic arteries sila. So naturally, napakaraming elastic fiber content. As compared to a muscular artery, meron ka bang nakikitang ganon? No? Yung mga parang swirly na structures dyan, wala. No? Actually meron, but konti lang as compared to the elastic arteries. Okay? And the muscular arteries, what's characteristic of them would be the prominent internal and external elastic lamina. Okay, so may ganito sila. Okay, that's quite prominent. So now let's go even smaller. No? The mga arterioles naman tayo. So these are considered to be resistance vessels. In fact, ang arterioles, they are the site of highest resistance in the cardiovascular system, and they play a major role in the regulation of blood pressure. Okay? They are highly innervated by the sympathetic nervous system, and they contain a single layer of smooth muscle. Okay, so you can see in this picture, ayan, no, meron siyang smooth muscle cell. So this allows it to play a role in the regulation of blood pressure. Okay, surrounding that, you have endothelial cells, and of course, in the lumen, you have those red blood cells over there. So again, comparing them side by side, you have an elastic artery over here. You have a muscular artery and an arteriole. No? So lahat sila may tunica intima, tunica media, and tunica externa. But yung difference is yung relative thickness. Again, kapag elastic artery, tignan nyo, napakakapal ng tunica media. Very prominent is the presence of elastic fibers. Sa muscular artery, less prominent na yung tunica media, no? Kumakapal na rin yung tunica externa. And then less din yung elastic fiber content niya. Sa arteriole, no, nagiging prominent yung tunica media only because it's so small, di ba? And the tunica media here is actually composed of a single layer of smooth muscle cells. Okay? Di ba alam natin ang smooth muscle cell because it's not striated, no? Wala kang nakikitang striation over there, and it only is composed of a single nuclei, and they are usually spindle shaped, no? Like this one, fusiform or spindle shaped. So you know it's a smooth muscle. And again, the arteriole important in the regulation of blood pressure. Capillaries, on the other hand, have an even smaller diameter, around 4 to 10 microns lang, whose wall is reduced to an attenuated endothelium, surrounded by a basement membrane, few pericytes, and connective tissue. Okay, they have very narrow lumen, okay, in such a way that only a single file of RBCs can pass through, and the capillaries would have the largest total cross-sectional and surface area. Okay? So, makikita ninyo dito sa picture, ayan, this is an capillary, and it would be lined by endothelial cells pa din. And see here, you have a single file of red blood cells, no? And yung red blood cells, saktong-sakto lang siya. Bakit? What is the diameter of a red blood cell ba? It's around 6 to 8 microns, right? Yung diameter ng capillary natin, 4 to 10 daw. Okay? So, it cannot fit 2. It can only allow a single file of RBCs to pass through. And this would, of course, facilitate then yung exchange of oxygen. Diba? The thin intervening space between the O2 and the red blood cells would allow more effective exchange of O2. So you have three different types of capillaries. You have the continuous, you have the fenestrated, and you have the sinusoidal capillaries. So when we say continuous, this is the most common type. At ano yung mga examples natin dito? You have the blood-brain barrier, you have the lungs, exocrine glands, the cardiac tissues, no? So those would have continuous capillaries. And then you have the fenestrated type, which has more extensive molecular exchange across the endothelium, no? And they have continuous basement membrane. So some examples include kidneys, no, the intestines, the choroid plexus, and endocrine glands. And lastly, yung sinusoidal, no, this would be more limited in terms of distribution. You only see it in the liver, the spleen, the bone marrow. Basically, ito yung mga organs of the reticuloendothelial system, right? Yung RES. So, they would promote maximal exchange of macromolecules and they would have discontinuous basement membrane. So, here is to show you, no, yung three different types that we mentioned earlier, continuous, fenestrated, and sinusoidal. Again, tingnan ninyo yung very prominent discontinuous basement membrane in a sinusoidal type of capillary. Okay? So, that's why tinatawag din siya minsan na open pore capillary. Okay, let's talk about the veins. Veins tend to have thinner walls. They tend to be more compliant as compared to arteries, and they are able to hold more blood. Okay, so when you look at histological sections, like say for example in this picture, makita nyo ito yung artery, ito yung vein. No, between the two, arteries tend to maintain their shape better as we compare them to veins, right? So, ang mga veins natin kasi, di ba, they are compliant. So, for example, pag nasa nasa wards tayo, pag meron tayong hypotensive patient, nagsashock, naka-nor-epi, or vasopressin pa, naka-triple pressors, di ba, it's very hard to collect blood from them, right? Hanap tayo ng hanap na ugat, pero collapsed yung vessels. Okay, so sometimes kahit anong tusok mo, wala talaga. Even if you're sure that there is a vessel there, that there is a vein in that area, pag tusok mo, walang dugo, nagbablock flow. Right? So, anong ginagawa niyo sa mga ganong situations? Naghahanap tayo ng artery, di ba? Arterial na lang. Okay, so, it's because of the intrinsic characteristic of the veins. Di ba? Compliant sila. So, pag mababa yung pressure, nagko-collapse din sila. Or pag hypovolemic, or decrease din yung blood volume, for example, sa mga dinudugo. So, nagko-collapse din yung vessels natin. Capillaries merge and they form venules. And of course, those venules would merge as well to form smaller veins and bigger veins hanggang they form yung IVC natin and the SVC natin. So, lymphatic vessels, they are thin-walled and they also contain valves, much like your veins. So, they have this continuous basement membrane and they also have three layers, tunica intima, tunica media, and tunica adventitia. So, you can see in this picture, no, meron siyang valves din, di ba? Para siyang vein, may valve din. But you would notice that the valve appears like floppy. And as you compare it to the vein, no, for the lack of a better term, parang mas makunat yung sa veins, di ba? As you compare it to the lymphatic valves. And that's it for anatomy. So now we proceed with physiology. Okay, so as a med student, I have to admit, physiology was really one of my weaknesses. Lalong-lalo na yung cardiovascular physiology because there are so many graphs, so many figures, ang dami-daming formula. No, tapos meron pa kaming mga weekly figure review, no, wherein you're going to present the figure, tapos tatanungin ka ng mga consultants. It was really, for me, napaka-traumatizing talaga ng experience. And in a way, I developed some form of an aversion towards physiology. And whenever I would see those formula, parang, ayoko na agad, no? So, I ended up committing the fatal mistake of just trying to memorize the formula, memorizing the information rather than understanding it. No, so pagdating sa board examination, talagang I spent extra effort with physio kasi hindi ko talaga siya naintindihan. Minemorize ko lang talaga siya. Okay, so if there are any of you who are on the same boat as me na nag-memorize lang din talaga, now is the time to really devote time, no, to understand the concepts. Because yung memory work is easy. Memory work follows after understanding the concepts. Okay, so that's what I realized come board examination pala na I should have really exerted effort trying to understand the concepts and memorizing, or rather, understanding the relationships rather than memorizing them. Okay? Sige, so let's proceed. So first off, we have velocity of blood flow. So this is explained by the formula V equals Q over A, wherein V is the velocity equal to the Q, the blood flow over the cross-sectional area. So what does this formula imply? So basically, ano ba yung essence niya? It's trying to tell us that the velocity is of course directly proportional to the blood flow and inversely proportional to the cross-sectional area of the blood vessel. So for example, it also goes to show that blood velocity tends to be higher in vessels with small cross-sectional area. So kung tatanungin kayo, no, which vessels tend to have small cross-sectional area, which ones tend to have large cross-sectional area? So saan mas mabilis ang blood velocity? Sa malaking vessel like the aorta, or would it be sa capillaries? Or maybe the better question is, which one would have a small cross-sectional area, which one would have a large cross-sectional area? So between the aorta and the capillaries, it's your capillaries that would have a large cross-sectional area. Therefore, it also follows that blood velocity is slower in your capillaries as compared to your aorta, which has a small cross-sectional area. Okay? So the velocity of the blood flow in the capillaries is actually tailor-suited to its function. Diba? Mabagal yung blood velocity doon. And that in that sense, no, it also optimizes the conditions for exchange of substances across the capillary wall. Right? Isipin mo kung bilis-bilis ng flow dun sa capillaries, we don't have enough time for exchange of materials across the capillary wall. Okay? So let's digest blood flow a little bit further. So here you have another formula. Q, which is the flow, is equal to the pressure gradient, designated as the delta P, over the R, which represents the resistance or the total peripheral resistance. So basically here you see cardiac output is equal to the mean arterial pressure minus the right atrial pressure over the total peripheral resistance. So this formula over here is analogous to the Ohm's law. So the main implication of this formula here is to say that blood flow is inversely proportional to the resistance of the blood vessels. Okay, so fairly straightforward naman yung concept. So let's try to explore resistance a little further. Now, tignan natin yung mga factors that would affect resistance. So this can be explained by the Pusui's equation. I think it's a French name. I'm not sure if I pronounced it right. No, hindi naman ako si Emily. So, baka mali. Pero anyway, wala naman yun sa exam. So, for your Pusui's equation, you have R as the resistance equal to the 8 times the viscosity of blood multiplied to the length of the blood vessel all over pi R being the radius to the 4th power. So what are some implications of this formula? Basically, resistance is directly proportional to the viscosity of the blood. Number 2, resistance is directly proportional to the length of the blood vessel. But resistance is inversely proportional to the 4th power of the vessel. So what are some clinical implications? So tignan muna natin yung mga directly proportional na relationship, the viscosity and the length. So say for example, we increase the viscosity. No? How do we increase the viscosity? No? By increasing the hematocrit. So say for example, patients with polycythemia. No, yung mga may polycythemia vera, taas ng hematocrits, di ba? Those who have hyperleukocytosis syndrome, for example, very viscous yung blood nila. No, those with multiple myeloma din. No, those patients with secondary erythrocytosis, be it if they are living in a high altitude environment, or smokers, polycythemia, and even patients with congenital heart disease. No, lalong-layo na yung mga may cyanotic heart diseases. Personal experience ko, the hemoglobin can go as high as 200s. Highest I've seen, 260. I tried to do therapeutic phlebotomy. Pagtusok ko, no, yung blood flow, very sluggish, nagbabara siya. And even I did phlebotomy lang, simple blood extraction, BE lang, hindi rin umaakyat yung dugo. No? So, ganun siya kalapot. Sobrang viscous talaga. So, that's very dangerous. So, imagine if you have a very high viscosity, what will happen? You will have a high resistance, right? And what will happen to the blood flow if you have a high resistance? Is it high or low? It follows that if you have high resistance, blood flow decreases. So imagine what will happen to the perfusion of the organs, especially yung mga sensitive to ischemia like the brain, the heart, diba? So if the blood flow in the brain and the heart are compromised, what can happen? So pwede sila magka-stroke, pwede sila magkaroon ng heart attack. Okay? So this is the reason why patients with those conditions that I mentioned earlier, we need to lower the viscosity of blood. Those with hyperleuk, kailangan i-hydrate natin sila. We can give leukocyte-lowering agents such as hydroxyurea. Those with polycythemia vera, we need to do therapeutic phlebotomy, or we can also hydrate them. Okay, so kailangan natin pababain yung viscosity to improve the blood flow. Okay, so other than this, no, how about if the radius gets affected? So, ito yung sinasabi natin kanina na very powerful relationship because it's R to the fourth power. So, meaning to say if the blood vessel gets narrowed, no? So, if the vessel radius decreases, say for example, bumagsak ng half, no? Nag-decrease by a factor of 2. Then the resistance will increase by a factor of, hindi lang double, but a factor of 16 because it's R to the fourth power. So, therefore, if the resistance increases by a factor of 16, what will now happen to the blood flow nga uli? Blood flow will decrease by a factor of 16. Okay? So, ganun siya kumbaga ganun kalaki yung effect ng radius doon sa blood flow and the resistance because it's to the fourth power. Okay? So, those are just some important clinical implications. So, in the vessel, you can have a laminar flow or a turbulent flow. So here in this figure, letter A, you can see that the flow is streamlined. No? So ito yung laminar. Okay? It's streamlined. They follow a straight line. Whereas si letter B, labo-labo. No? So this one is a turbulent type of flow. So how do we now differentiate, no, or predict if the flow becomes laminar or will it be turbulent? So we have the so-called Reynolds number. Okay, so this is your Reynolds number. And what's important here is to look at the relationship of the factors involved. So, ingat, no? Kasi meron tayo malaking V, capital V, and merong small v, and they are very different, no? So, look at the legend below. So, tingnan muna natin tong una dito. So, this one implies that the Reynolds number would have a direct relationship with the density. The big V is velocity, and then the length, all over the bulk viscosity. Okay? And then, another relationship would be in that Reynolds number is equal to the velocity times the length all over the kinematic viscosity. Okay, so directly proportional to the velocity, inversely related to the viscosity. Okay, so don't be confused. So Reynolds number will help predict whether the blood flow in a particular vessel will be laminar or turbulent. So if it's high, no, when the Reynolds number is increased, usually around 4,000, above 4,000, there is a greater chance for the blood vessel to have turbulent flow. And this turbulence leads to audible vibrations called bruits. So a good specific example here is in patients with stroke. Part of the workup in patients with stroke would be to auscultate for the presence of carotid bruits. No, kasi minsan may mga atheromatous plaques na nagto-throw, no, leading to the stroke. No, part of the workup includes a 2D echo and carotid artery Doppler studies. Okay, so yun siya, no? So, what are the factors nga uli? Viscosity and velocity na mention natin kanina. So, Reynolds number is increased by an increase in velocity, but it is increased by a decrease in viscosity. Okay? So, ano yung mga specific examples ng decreased blood viscosity? Anemia, low hematocrit. Okay? So, ibig sabihin, kapag mababa ang hematocrit, mataas ang Reynolds number, pwedeng mas turbulent. So, in patients with anemia, pwede tayo makarinig ng bruit at murmur, di ba? Hemic murmur. Okay? So, basically, a murmur outside of the heart in the vessel, it's what you call a bruit. Okay. How about increased blood velocity naman? In cases of a narrowed vessel, stenotic vessel. So, pwede mag-increase ang Reynolds number. You expect turbulent blood flow. So when we talk about shear, this time, this is a consequence of the blood traveling at different velocities within a vessel. So you can see here that in the middle, no, in the center, the blood velocity is constant. So velocity, on the other hand, is 0 at the wall and it is highest, therefore, at the center of the vessel. Baliktad sila ng shear. So the shear is therefore highest at the wall and lowest at the center. Okay, so yun yung pinaka-important lang naman dito is the baliktarang relationship ng velocity and the shear. So basically, when we say contractility, this refers to the intrinsic ability of the cardiac muscle to develop force at a given muscle length. Basically, this is the same as saying inotropism, and this is related to the level of intracellular calcium concentration, which I will show you later on. So when we say positive inotropy, or if you give a positive inotropic agent, you increase the contractility, and the reverse is true. So when you say negative inotropy or negative inotropic agent, we decrease the contractility. So what are the factors that can increase contractility? So number one, interesting to note that an increase in heart rate can actually cause an increase in the cardiac contractility. Okay, number two, sympathetic stimulation of the B1 receptors, no, beta 1 receptors. Number 3, cardiac glycosides, basically example digoxin. Okay, all of these mechanisms would all boil down to calcium. Okay, as mentioned, contractility is related to the level of intracellular calcium. So how does an increase in heart rate cause an increase in cardiac contractility? So I tried to simplify this and summarized it with 4 simple steps. Basically, if you have an increase in the heart rate, there are more action potentials that occur per unit time. So more calcium enters the myocardial cells and more calcium is released from the sarcoplasmic reticulum. Remember the concept of calcium-induced calcium release? So basically, di ba sariling sikap talaga to, puro calcium to doing all the work. And basically, greater tension is produced during each contraction if you have more calcium in the cytoplasm. So for us to be able to understand the previous concept better, let's have a quick review of the cardiac myocyte physiology. Remember, it all starts with calcium going inside of the cardiac myocytes. So punta tayo dito. Okay, so action potential is generated. You have calcium entering the cardiac myocyte through the L-type calcium channels. Pasok siya doon. Pagpasok niya doon, it will interact first with the ryanodine receptors of the sarcoplasmic reticulum. And remember, what is the role of the SR? The sarcoplasmic reticulum is the storage site of calcium. And interaction with the ryanodine receptors will lead to release of calcium, no? So ito yung tinatawag natin ultimate sariling sikap, calcium-induced calcium release. Okay, and upon release of that calcium, it will bind to the troponin C, leading to interaction of the actin and the myosin, eventually leading to contraction. Okay, so basically, dito pa lang sa umpisang part na to, pumapasok yung increase in heart rate. Because sabi natin, if you have increased heart rate, step 1, you have more action potentials generated per unit time. Okay? Therefore, down the line, you have increased contraction, increase in cardiac contractility. Second factor that we've mentioned, sympathetic stimulation of the beta 1 receptors. So actually, pareho lang din to. No? So basically, stimulation of the beta 1 receptors will cause an increase in the inward calcium current. And you know what happens, diba? Whenever you have increase in inward calcium, there is more activity of the calcium pump of the sarcoplasmic reticulum, more calcium available in the cytoplasm to interact with the troponin C, leading to more contraction. Okay. And then last, no, sa mga factors increasing contractility, you have cardiac glycosides or digitalis, specifically digoxin. Okay, so how does this work, no? Konting kwento, back in the day, no, when digoxin was discovered, it was treated like some sort of a wonder drug. People were so amazed about its effects because no, parang it improves cardiac contractility nga without affecting much the blood pressure. Say for example, in patients with heart failure na may AF, atrial fibrillation, pag nabigay ka ng beta blockers sa patients with marginal BP, no, pwedeng bumaba ang BP, right? But when you give digoxin, hindi niya masyadong naapektuhan kasi yung blood pressure, no? So it does not cause hypotension. So pwede nating ibigay yon. So how does it work? No? Pinaka-important concept is to recall that it actually inhibits the sodium-potassium ATPase pump. Two pumps or two channels that we need to remember here. One would be the sodium-potassium ATPase pump. Second is the sodium-calcium exchanger. Ano ba ang ginagawa ng sodium-potassium ATPase pump? Remember the acronym PISO. No, palatandaan ko yung college days pa. Proud na proud. Potassium in, sodium out. Ulit, PISO, potassium in, pasok, sodium out. Okay. How about the sodium-calcium exchanger? The role of sodium-calcium exchanger is to extrude intracellular calcium. Okay? In replacement of sodium. So, labas si calcium, pasok si sodium. Yun ang role ng sodium-calcium exchanger. So, what will happen now if you give digoxin, digitalis, that will inhibit sodium-potassium ATPase? Si sodium hindi makakalabas. Diba? So, if sodium is not able to go out, we are effectively increasing the concentration of sodium inside, intracellularly. Tumataas si sodium. Punta tayo ngayon sa next channel. Ano ba ang role ng channel na to ulit ni sodium-calcium exchanger? It will extrude calcium in exchange for sodium. Pero ang dami-dami ko ng sodium, ayoko na ng more sodium. 'Di ba? So, therefore, if inhibited pala tong channel na to, si sodium-potassium ATPase pump, the gradient, no, or the sodium actually decreases. 'Di ba? So, ayaw na natin ng more sodium. So, it will actually diminish the activity of this channel. So, ano nangyayari? Hindi na tuloy ngayon papasok si sodium in exchange for calcium. Thereby, you're actually preserving or increasing the levels of intracellular calcium. Okay? So, again, more calcium inside the myocardium, more contraction. Diba? At the end of the day, it's still calcium. Okay? So, that's the main essence. Okay, so how now do we decrease contractility? So basically, this is just like a reverse of the concepts that we discussed earlier. So one example would be parasympathetic stimulation via the muscarinic receptors. So if we decrease the inward calcium current, we decrease the force of contraction. Ganun lang yun. Diba kanina, increase calcium, increase contractility. Ngayon, less calcium, less contraction. Okay? And in the same way, na beta stimulation can increase the cardiac contractility. Giving beta blockers will decrease naman cardiac contractility. Okay? So now let's proceed to another topic. Let's talk about the Frank-Starling relationship. So this basically describes the increase in stroke volume and cardiac output as a response to an increase in venous return or end diastolic volume. So basically, this is a length tension relationship, and the greater the venous return, the greater the cardiac output. Okay? So, pag sinabi nating end diastolic volume, no? So, basically, same lang yun, no? Same as saying venous return. If you increase the end diastolic volume, what will happen? More stretching, right? It will cause an increase in the ventricular fiber length, no? At pag nag-increase yung length, it will increase the tension as well. Therefore, you will have an increase in the stroke volume consequently. So, tingnan natin siya as a graph. So, let's try to identify the parts of this graph. On your y-axis, you have the stroke volume or the cardiac output. And on your x-axis, you have the right atrial pressure or the end diastolic volume. Basically, the venous return. So, you can see here yung the green line, this is the control, showing you that as you increase the end diastolic volume, ano nangyayari dun sa stroke volume? There is a direct relationship, right? So, habang tumataas ang EDV, tumataas ang cardiac output, tumataas ang stroke volume. And of course, if you increase the inotropy, if you give drugs that have positive inotropy, you shift this line to the left, no? So, ano nangyayari? Mas napopotentiate kumbaga yung relationship ng increase in the EDV with the increase in stroke volume. Okay? So, as evidenced by the blue line. And of course, the reverse is true if you give a drug that will cause negative inotropy. Okay? So, ganun pa din. As you increase the end diastolic volume, you will be able to increase the stroke volume, but the relationship is less, kumbaga, if you give negative inotropic drugs. Now, let's go to the cardiac action potentials. So, you have here two figures that would highlight the cardiac action potential. Pero magkaiba sila. So, alin ba dito yung mga nakikita natin sa mga normal cells of the heart? Alin ba dito yung mga specialized cells of the heart? The one on your left, would be the figure that would match the action potential seen in the ventricles, the atria, including the Purkinje system. The one on your right, this one is quite special, no? Only in pacemaker cells, example in those seen in the SA node. Okay. So some generalities, no? So when we say resting membrane potential, this is determined by the conductance to potassium, no? So that's why at RMP, we expect that this would approach the potassium equilibrium potential. Now let's define a few terms. Ano bang ibig sabihin pag sinabi natin depolarization, and what does hyperpolarization mean? So an inward current that brings about a positive charge into the cell, you call it depolarization. In short, you make the membrane potential more positive. You depolarize it. Paano naman kung outward current brings positive charge out of the cell? You call it now hyperpolarization. In short, you're making the membrane potential more negative kasi nilalabas mo yung positive charge out of the cell. Okay? So let's take a look at the image or the figure. So now let's look at the cardiac action potential as seen in the ventricles, the atria, and the Purkinje system. Focus your attention on the figure here. So you can see that there is a phase 0, phase 1, phase 2, phase 3, phase 4. Kompleto. So isa-isahin natin, no? What does those phases mean? At phase 0, no, you have an increase in the sodium conductance resulting in an inward sodium current that depolarizes the membrane. So from the resting membrane potential that approaches the potassium equilibrium, you now have an increase in sodium current, inward sodium current. Pasok si sodium. Ano ba si sodium? Sodium is positively charged. So ano mangyayari? You make it more positive. Kaya siya nag-shoot up ng ganon. You make it more positive, you depolarize the membrane. Okay? And this is the reason why at the peak of the action potential over here, the membrane potential actually approaches the sodium equilibrium potential. Okay? Itong sa ilalim potassium, itong tuktok, sodium equilibrium potential. Next, phase 1. Yung phase 1, itong maliit na nakausli lang dito, no, napababa. Phase 1 is a brief period of initial repolarization. Okay? So it follows that if there is an initial repolarization, merong succeeding repolarization, yung todo-todo na talaga, which comes in phase 3. Pero dito muna sa phase 1, this is brought about by the movement of potassium out of the cell. And what is potassium? Potassium is positively charged. So kapag lumalabas si potassium out of the cell, you make it more negative. Okay, so yan, bumaba siya. Next, sa phase 2, this is the plateau phase, no? So ito siya, no? So what is responsible for the phase 2? Bakit nagpla-plateau? Because by phase 2, you have an increase in the calcium conductance, inward calcium conductance, and increased potassium conductance. So anong pinagsasabi nun? Basically, you have an outward and inward current that are approximately equal. So sino ba yung lumalabas? Potassium lumalabas. Sino yung pumapasok? Calcium pumapasok. The outward and the inward current are approximately equal, so plateau siya dito. Okay? So membrane potential is stable during this time. By phase 3, lumagapak, no? Nag-repolarize siya. And what is responsible for the phase 3? It's because of the potassium conductance. So the calcium conductance will decrease, and now, kumbaga, mas marami na, no? The high potassium conductance results in a large outward potassium current, no? So ano nangyayari dito? Nagkakaroon na ng hyperpolarization. Okay? So you bring the membrane back towards the potassium equilibrium potential, which is basically the phase 4. Okay? So stable na siya uli dyan. What is the difference now kapag SA node ang pinag-uusapan? Pacemaker cells have a unique characteristic, no? So SA node is the normal pacemaker of the heart. It has an unstable resting potential. Okay? So ito yung important dito. The phase 4 depolarization brings about the automaticity. So the intrinsic rate of the phase 4 depolarization would be fastest in the SA node, followed by the AV node, and then the His-Purkinje system. Okay? So kaya ang His-Purkinje, the AV node, we call them latent pacemakers because they also exhibit automaticity, but they are latent. Meaning to say, if the SA node is working fine, tumatakbo, the heart is firing at the rate that the SA node is dictating, si AV node at si His-Purkinje quiet lang sila. They are latent. But say for example, SA node is suppressed. Okay, nagkaroon ng problema sa SA node, the AV node will override this SA node. Okay? So, maghahari-harian siya. And the heart will now contract based on the rate na dinidictate ng AV node or the His-Purkinje system, which is usually slower than the SA node. So, balik tayo ngayon sa action potential. So, the picture on your right now describes the action potential that we see for pacemaker cells, particularly that seen in the SA node. So, you have a phase 4 over here, very unique. No, unti-unting umaakyat, and then phase 0, naalala yung phase 0 kanina, it's depolarization, right? Ganun din dito, depolarization. But, very, very different in such a way that the depolarization for pacemaker cells is brought about by the calcium conductance. Okay, naalala kanina, for your usual cells, sino ba ang nag-bring about ng phase 0 depolarization? It's the sodium, no? The inward sodium current. This time, anong pinakaiba? It's the calcium that goes inside. Okay? So, therefore, ano mangyayari if it's all about the calcium now? You drive the membrane potential towards, the calcium equilibrium. Okay? So, in a way, we can say that the ionic basis for phase 0 in the SA node is different from that seen in the ventricles, atria, and the Purkinje fibers. Okay? So, next, ano pang pinagkaiba? Ito, phase 4, phase 0, phase 3. Wala siyang phase 1, wala siyang phase 2. Diba? So, from phase 0 na depolarize na siya, what will happen next? Phase 3 is repolarization brought about by the increase in potassium conductance. Okay? So, this will bring about an outward potassium current that causes repolarization. And what can you say? Comment. Pareho ba to o magkaiba dun sa kanina na pinakita natin? It's the same. Diba? Basically, in phase 3, you bring it back towards the potassium equilibrium potential. You make it more negative. Okay? Tapos, babalik na naman siya. So, sa phase 4 na naman siya, unti-unti na naman. Okay. So, phase 4 is characterized as slow depolarization. Ayun, unti-unting nagiging more positive hanggang mag-shoot up, kumbaga yung increase in calcium current. No? So this phase 4 is the most important aspect of the cardiac potential action potential, because it accounts for the pacemaker activity of the SA node. So kung walang phase 4 na slow depolarization, there will be no automaticity. And in essence, wala tayong pacemaker cells. Okay? So it accounts for the pacemaker activity of the SA node, and it's caused by an increase in the sodium conductance. Okay? And you call it the inward sodium current na IF yung channel. Funny channels. Okay? So as noted, wala tayong phase 1, wala tayong phase 2. A little bit of clinical correlation. So here is your IF, no? Yung funny channels natin. Ano nga yung tinatransmit niya? It's sodium, di ba? So it's actually selectively inhibited by a drug which we call ivabradine. Okay, so ivabradine will target specifically the IF current. And where do you see it? You see it in the sinus node. Okay? So that's why ivabradine is a drug that we can use in order to decrease the heart rate. But there is a caveat here. Hindi siya pwedeng gumana sa patients na hindi sinus ang rhythm. So for example, patient has atrial fibrillation with heart rate 160, 180. Kahit lunurin mo ng ivabradine, hindi siya gagana. Bakit? Because ivabradine targets specifically the IF channels, no, that we see in the SA node. In atrial fibrillation, hindi nga siya sinus, di ba? Wala tayong P waves. So, kumbaga yung ventricles are contracting independent of the atria. Okay? So, may disorganized na contraction tayo. So, it will not work for patients with atrial fibrillation. Okay? And in physiology, paano natin i-describe yung activity na ivabradine? You can see na bumabagal siya. Tingnan nito guys, no? So the phase 4 depolarization is slowed down because of ivabradine. Okay? So nagkaroon ng parang shift to the right. Okay? Bumagal siya. Okay? So that's how you decrease heart rate through the use of ivabradine. Now let's go to a very familiar figure. Alam ko ito, lahat nakita nyo na to. And it's one of those figures na kahit ilang beses mong basahin after exam, makakalimutan mo na siya uli. Okay, but it's actually very important, and the key here is to digest it part by part. No, kasi ang dami-dami nangyayari, no? It lumped together everything na mukha tuloy siyang overwhelming. Okay, so let's try to look at it part by part para mas maintindihan natin. Okay, so let's take a look at the parts one by one para mas maintindihan natin kung bakit ang dami-daming nangyayari. O, di ba? So, clean-up ko siya para mas mukha siyang less overwhelming. Okay, so the first part over here would highlight the events that happens in the heart. Basically, yung cardiac cycle. The actual events that happen. Yung nasa ilalim, this would represent the heart sounds. Okay? Correlating it with what's happening in the heart. Okay? Yung itong purple na line over here, this will tell us the ventricular volume. Okay? So kung dumadami ba yung volume, lumalabas na ba siya, na-eject siya, bumababa na ba siya, you can see it here. This one is the venous pulse pressure, and lastly, you have the ECG tracing over here. What's good about having this ECG tracing over there is that you can use the ECG as an event marker. Okay? So now let's try to discuss the cardiac cycle. Just to avoid confusion, remember it's a cycle. So anywhere you begin, technically you will end up in the same spot. So there is really no step one, there's really no fixed point at which we should begin. But for purposes of uniformity, let's try to follow the designation given here in this figure. So let's start with letter A. The letter A in this figure is atrial systole. And when we say atrial systole, that's atrial contraction, right? So atrial contraction will contribute to ventricular filling. So you can see that the volume of your ventricles will increase slightly over here, and that the LV pressure will also increase somewhat, a little bit only. Okay? Because alam naman natin that ventricular filling will happen even without atrial contraction. It contributes, but kumbaga it is not a requirement. Okay? So the increase in atrial pressure will be evidenced by the presence of the A wave in your venous pulse pressure over here. Okay? So you have filling of the ventricles. Nakita na natin yan dito sa purple line. And in certain instances, you might be able to hear a fourth heart sound. Okay, so pag may fourth heart sound, ibig sabihin may turbulence, no? Bakit kaya? The fourth heart sound, or the S4, is actually the so-called atrial gallop. Okay, so this will happen if there is an LV that is non-compliant. The fourth heart sound should not be audible among normal adults, no? So pathologic yun pag nakarinig tayo ng ganun. Bakit? So imagine if you have the LA contracting against an LV that's not compliant, so parang it can cause turbulence, no? So it will produce the S4 heart sound. Okay, so again, not normally heard among normal individuals. Second event, which is isovolumetric ventricular contraction. So when we say isovolumetric, meaning to say that the volume is constant. So puntahan natin yon, no? Ventricular volume. Tignan nyo dito, the purple line is constant, no? Isa siyang flat line. So here, the AV valves close when the ventricular pressure becomes greater than the atrial pressure. So if the AV valves close, no, it will create a sound, no? So this will correspond to the first heart sound, the S1. Okay? So tignan natin siya dito. Ayan, no? So the mitral valve closes, the AV valves, no? So this will correspond with the S1 heart sound. Walang change in the volume. Okay. So during isovolumetric ventricular contraction, the ventricles do contract, no, as evidenced by the ECG. Nakita nyo may QRS, di ba? And you know that the QRS will represent ventricular contraction. But what will happen? Dahil sarado pa ang aortic valve, ano mangyayari? Tataas lang ang pressure sa LV, pero hindi mag-escape yung blood. Sarado yung valve eh. 'Di ba? Sarado si mitral, sarado si aortic. Where will the blood go? Nowhere, 'di ba? So it will just increase the pressure in the LV, causing now a rise, no, dito sa LV pressure na to, tong red line natin. Okay? But purple line, again, straight line siya. No change in volume. Next, what will happen now, no, if the ventricular pressure overcomes the aortic pressure? So the aortic valve opens. So when the aortic valve opens, the blood will escape. So this is what you call the rapid ventricular ejection, and this is evidenced by a rapid decline in the ventricular volume, as you can see in the purple line, no? Very steep. Okay, nababagsak siyang ganun. Okay, at this point, most of the stroke volume is ejected. So dito naman sa LV pressure natin, paakyat-akyat pa din yan. Okay? So, pag titignan naman natin guys yung ECG tracing natin, you have the T wave, no, the onset of the T wave specifically that will mark the end of rapid ventricular ejection. Because ano nga uli ang T wave? What does it represent? It represents relaxation, di ba? Ventricular relaxation. So, reduced ventricular ejection. Syempre, hindi naman pwede todo-todo akyat lang na akyat yung pressure, di ba? At one point, mauubos din naman yung volume na ina-eject niya. So at that point, unti-unti nang babag-drop ang ventricular pressure natin, no? Sa LV ventricular pressure, the volume isn't so drastic na at this point, and the aortic pressure decreases now because of the runoff of blood. Okay? So ayan na siya. Yung broken line dito na color blue will represent the aortic pressure. Next, you have the isovolumetric ventricular relaxation. So nasaan yung point na yon? This is at point E. Again, pag sinabi natin isovolumetric, same volume, the valves are closed. Okay? So repolarization of the ventricles is complete. So dito sa E na to, no, tingnan ninyo siya sa ECG. After the T wave na siya. Meaning to say, after the ventricles have already relaxed, repolarized. Diba? Okay. So at this point, no, you have the aortic valve which closes. And of course, at this point, the mitral valve is yet to open. Okay? So at this point, E, the volume is constant and the ventricular pressure drops rapidly. Okay? So sometimes you can see the incisura or the dicrotic notch, hindi naman siya ganun ka-clinically significant. Over here, you know, yung blip over there is what you call the incisura or the dicrotic notch. Okay? So now let's proceed to rapid ventricular filling. So this is phase F in the figure over here, and you can see how the onset is marked by the opening of the mitral valve. So the moment that the mitral valve opens, okay, ventricular filling from the atrium begins. Okay? The rapid flow of blood from the atria to the ventricles will lead to the production of the third heart sound. So this can be normal in children, but it's pathologic among adults. Okay? So you can see that the volume at point F, there is a rapid increase in the volume. No, yung purple line natin, very steep increase siya. So now we proceed to the last phase, which is the reduced ventricular filling or diastasis. So this is point G in the figure, and this is actually the longest phase of the cardiac cycle. So at this point, no, open pa ang mitral valve natin, but of course, nauubos, unti-unti naman na nauubos yung blood that's flowing from the atria to the ventricles, right? So you can see that the ventricular volume is still going up, but at this point, it's no longer as steep. Right? So medyo curved na siya na pag ganon. Pero umaakyat pa din. So increases in heart rate will decrease the time available for ventricular filling. So ito yung phase that gets compromised on the background of tachycardia. Okay? So and then after this phase, eventually babalik na naman tayo sa umpisa, yung atrial systole na naman. Okay? So pabalik-balik lang sila. So now let's touch a little bit on electrophysiology. So this will entail understanding of the cardiac cycle. Diba? As we mentioned earlier, so yung P natin dito, this is atrial contraction, and it will be followed by atrial systole. Diba? Yung kanina natin diniscuss. And then you have the QRS, marking ventricular depolarization, and then you have the T wave, which marks ventricular relaxation. So this will be vital in understanding the concepts behind a normal ECG. So now let's try to review how a normal ECG looks like. So of course, alam natin pag ECG may wave, may intervals, no, may segments. Okay? So yung mga segments are actually isoelectric points. The intervals, no, they represent a duration of time, kumbaga. No? So tingnan natin, no? So when we say P wave, ito siya. But when we say PR interval, it starts from the beginning of the P wave all the way until the start of the QRS complex. So ito siya. Okay, so the PR interval is important because increase of that can represent a block. Okay, so next you have a QRS complex from the start of the Q, no, all the way until the S goes back up to the isoelectric point. No, so yun yung QRS duration natin or the QRS interval. Next you have the T wave, which represents ventricular relaxation. So the time from the start of the QRS all the way until the ventricles have relaxed the T wave represents the QT interval. So this is important, no? So the U wave, on the other hand, this will come after the T wave. And it's not a normal finding. Yung U wave could be representative of hypokalemia. Okay? And then you start another PQRST na naman. Okay? So the point of R to R interval will help us determine the rate later on. So again, just to review, atrial depolarization would be the P wave. Pero nasa ng atrial repolarization? remember, everything that depolarizes should repolarize, di ba? Because it could not just depolarize and depolarize. But remember that the amplitude of the atrial repolarization is very small, no? It's already being buried by the huge QRS complex here. Okay? So, hindi na natin na-appreciate, kumbaga, yung atrial repolarization. Okay? But tiwala na lang na nangyayari siya. Okay. PR interval varies with conduction velocity through the AV node. So, say for example, you have a first degree AV block. You expect the PR interval to lengthen. No? Usually more than, 5 small squares na siya. QRS complex over here represents depolarization of the ventricles. QT interval, ito yung sinasabi kong important, no? Because there are certain drugs that prolong the QT, no? And there are certain drugs that shorten the QT. So if a drug is known to prolong QT, like the common antibiotics, levofloxacin, the macrolides, azithromycin, no? You might have to avoid it habang prolong pa yung QT so that we don't put the patient at risk of developing arrhythmias. So when you're in the clinics or when you're in the wards, make sure that you check for the QT interval before you administer medications. So the QT interval, ito siya, will actually represent the entire period from depolarization to repolarization of the ventricle. Okay? So the ST segment over here is an isoelectric point. No, it represents a period where the ventricles are still depolarized. No, kasi bago pa mag-T-wave, bago pa mag-repolarize. The T-wave represents relaxation of the ventricles, and then you start another cycle. So in terms of lead placement, nice to know. I think mas important siguro malaman yung placement ng chest leads, okay, rather than the limb leads. Kasi ito may mga landmarks tayo. No? Siyempre yung limb leads, obvious na yon. Ilagay mo sa right arm, left arm, di ba? Pero ito, may mga landmarks kasi tayong tatandaan and it might be useful kung wala yung ECG technicians natin. So what do we need to remember? V1 is in the fourth intercostal space, right parasternal siya. Okay? It's in the right parasternal, fourth intercostal space. Going to the V2, so basically, ilalagay mo lang siya on the left-hand side, fourth intercostal space pa rin, parasternal. Yung V3, skip mo muna yan. No? Bakit? Kasi ang landmark mo is not the V3 but the V4. The V4 is in the fifth intercostal space, mid-clavicular line, around 9 centimeters from the midline. Very easy to remember. So, pag tansyahan na lang, below the nipple, you put V4 over there. So, kung meron ka ng V2, meron ka ng V4, tansya, lagay nyo si V3 sa gitna. Okay? So, the landmark of V3 is midway between the V2 and the V4. Next, V5, no? Si V5 is in the anterior axillary line, and then the V6 in the mid-axillary line. Okay? So, kulang yung leads na nilalagay niya rito. Hindi pa niya nalalagay si V6, mid-axillary. There you go. Itong point over here, that's where you put the V6. Okay? So, ulit, very, very quickly, you have V1, right fourth intercostal space parasternal. V2, fourth intercostal space left parasternal. V4 is below the nipple. V3 is midway V2 and V4. V5 is anterior axillary. V6 is mid-axillary. Okay? So, tandaan na yan. So, at this point, let's practice reading ECGs, no? So, maglabas tayo ng calculator. Bring out your phones. I want you to practice them together with me. Okay? So, gusto ko, kumbaga, natatry nyo rin personally para you learn by doing. Okay? So, when you're reading an ECG, it has to be systematic. Okay? You start with determining the rate and the rhythm, no? So, meron tayong acronym dyan. It's not standardized, no? But yung nakasanayan naming acronym dyan is RAHIM. No? So you start with the rate, the rhythm, you check the axis, and then you check for presence of hypertrophy, ischemia, or infarcts, and then miscellaneous if there are other findings. So let's start off with determining the rate. Okay, so the rate, meron tayong formula kung regular. No? So titignan nyo muna siya. You look at lead 2. Lead 2, no, is the rhythm strip. So, di ba, yung mga ECGs natin, usually they have a long lead to sa baba, no? Or sa gilid. So, you check, no? Pantay-pantay ba siya? No? Kumbagang R to R interval natin, pantay-pantay ba kada set? If it's pantay-pantay, then you can use this formula. 1,500 divided by the number of small boxes between R to R. Alin yung small boxes na yan? Ito, guys, no? So, yung mga maliliit na box dito, that's 1, 2, 3, 4, 5, no? Those are the small boxes. Or alternatively, you can use 300 divided by the number of the big boxes between R to R. Okay. So, mas mahirap lang magbilang ng big boxes kung hindi siya sumasakto dun sa guhit, right? So, subukan nating bilangin to. Ito naman, grossly, no, by eyeballing, you can say na, it seems regular. So, let's count, no? Bring out your calculators or your phones. So, 1,500, no, divided by the number of small boxes. Ilan ang small boxes, guys? Ito, so from R to R, that's 4, 9, plus 5 is 14, plus another 5 is 19, tapos dalawa pa, so 20, 21. So, 1,500 divided by 21. Key it in your calculators. What did you get? So, the answer here is 71. Okay? So, correct? 71 yung nakuha ninyong value. Alternatively, we can do 300 divided by the number of the big boxes between R to R. Ilan ba yung big boxes dito? So, 1, 2, 3. Tapos, merong isang alanganin, no? Pwede natin pag-combine. 4. Sige, tansyahan na lang. Nagmamadali ka kunwari. 300 divided by 4 is 75. Right? So, kita nyo, hindi naman siya earth-shattering difference. 71, 75. You get the point. Okay? What if, umipiyok, what if it's irregular? Say, for example, the patient has atrial fibrillation or the rhythm is irregular. Okay, so you cannot use this formula kasi yung R to R nito, iba sa R to R yung kasunod, no? So that would be very misleading. So what you do is you count a 6-second strip or basically you count 30 big boxes. Okay? So for example, ito 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 all the way until you count 30. Okay? Tapos, bibilangin natin ilan yung QRX complex na nasa 30 na yon, no? Sa 6-second strip na yon. And then you multiply it by 10. So, say for example, AF in RVR siya, meron siyang 11 na QRS complex. Random number lang yun, ha? Baka magtaka, saan ang galing yung 11? So, example, there are 11 na QRS complexes no sa 6-second strip nyo. You simply multiply it by 10, you get 110. Diba? Very simple. So for the next step, we want to determine the axis. So for the axis, there are a variety of ways by which we can measure it or we can get it. So we can have the quadrant method or two-lead method, vector analysis, or you can compute for it. No? So paano ba natin kino-compute? Basically, you need to count the number of squares in the AVF and lead 1, and then you multiply it by 90. No? 90 times AVF divided by 1 plus AVF. Ulit, 90 plus AVF, the entire thing divided by 1 plus AVF. Okay? So, dun sa two-lead method, no, usually we use this shortcut method. Okay? Because it's hard to compute all the time, especially when you're in a hurry. Diba? Maglalabas ka pa ng cellphone, magko-compute ka pa. No? And usually naman, it gives us an idea, no, whether it's normal axis or possibly may lag or even right axis deviation. So you can see in this slide, no, that there are a variety of conditions that are associated with axis deviations, no? But of course, this is not kumbaga 100%. Hindi porket may axis deviation na automatic 100% sure ka na mayroong pathology because of course, there are a lot of factors that can affect the ECG. The integrity of the ECG or the quality of the ECG, di ba? Say for example, yung mga chest wall factors like edema of the chest wall. Mataba yung patient, makapal yung fat, or sobrang payatot ng patient, no? Taas-taas ng mga complexes natin. So there are really a lot of different factors, no? Technical issues can also play a role, no? So hindi porket sa ECG natin may ganitong finding, automatic yun na talaga yun. But it gives us an idea. So how do we do the shortcut? No, ito lang yung pinaka-important na kung makakalimutan nyo man mag-compute, okay lang sa akin. But what I want to impart for this session, yung bawal na bawal makalimutan, is how to determine the axis using the shortcut method na lang, no? So, lead 1 and AVF ang titignan natin. Okay, tandaan na yun ngayon. We look at lead 1, you look at lead AVF. Okay? So, yung thumbs ninyo, ganyanin nyo siya para maalala nyo. Okay? If both are positive, ito, yung nasa left, yung left na kamay ninyo, that's the lead 1. Yung right na kamay ninyo is the AVF. Okay? Tandaan nyo. Lead 1 left, right is the AVF. If, for example, both are looking up sa ECG, yung QRS pataas. So, thumbs up, Both positive, normal axis. Good. Paano naman kung si lead 1, no, yung left mo, positive siya, pero yung AVF mo, negative, pababa. So, thumbs down. So, yung left hand ko yung nakataas. So, it's left axis deviation. What if naman baliktad? Yung lead 1 ko, pababa. Yung AVF ko, pataas ang QRS complex. So, yung right ko yung nakaturo pataas. So, it's a right axis deviation. Pag both pababa, negative, negative, that's extreme axis deviation. Okay, so that's how I remembered it. So, let's practice determining the axis. Again, what leads do we look at? Ano nga uli yun? So, we look at lead 1, and lead AVF. Okay. So, nagmamadali ka. Say, for example, so, how do we do the shortcut method? No? Paano para mabilis? Malaman mo agad. Okay, so lead 1 is up. AVF is also up. 2 thumbs up, so it's going to be normal axis. Okay? Move on tayo. Let's check another example. Okay, so now we have another strip. Try tayo mag-practice. Apart from the axis, no, I want you to practice determining the rhythm as well as the rate. Okay, I'll give you a few seconds. Analyze this strip. Is it regular or irregular? So you can see that the R to R intervals are roughly the same, right? Even eyeballing, you can see na pare-pareho yung sukat nila. If you're having a hard time, you can get a piece of paper, lapat nyo dun sa ECG, and then you can mark the R with a pen para makita nyo talaga yung intervals, whether they are really regular or not. Okay? But this one, grossly, we can say that it's quite regular, right? So, regular siya. If regular, we can use our formula na 1,500 divided by the number of small squares from R to R. Remember, kapag irregular, hindi yun pwede. You get a 6-second strip, you count the number of QRS complexes. So, grab your calculators, let's compute. So, 1,500 divided by the number of small squares from R to R. Sige, pakibilang nga, practice tayo. Okay, were you able to count the number of small squares? So, tignan ninyo, no? So, an easy way for you to be able to count it, no, pipili kayo ng QRS na nakasakto na dun sa guhit. Di ba? Para hindi kayo nalilito. So, say for example, this one, sakto siya dun. So, that's 5, 10, 15. Tapos, meron pang konting butal dito, no? It did not fulfill the entire box, no? So, around 4 to. So, 19, right? So, 1.5 divided by 19 is 78.9. So, around 79. Okay, so pasok siya sa normal. Okay, so were you able to get that? Okay. Tapos, next, magbilang tayo ng axis, no? Let's try to do the two-lead method, o yung shortcut na tinatawag. Let's look at lead 1 and lead AVF. Lead 1 is upright, no? Yung QRS niya upright. Yung lead 2 niya, paano? The QRS is on the negative side, so it's down, no? If it's up and down, ano nga yun? How do we interpret that? It's a possible left axis deviation. Okay? Pero gusto ko mag-practice tayo mag-compute, no? Because we want to be sure. Sometimes, grossly, it looks like it's a LAD, but when you compute, it actually does not fulfill the criteria. Tignan natin. What's the formula again? It's 90 times AVF, no? So, 90 times AVF over 1 plus AVF. Sige nga, try to compute. Sige, compute with me, no? Pag sinabi nating AVF, ilang boxes yung AVF natin? Okay. So, you have ilan to? So, this is around 6 boxes pababa and then around 1 box na upright, no? So, minus nyo yun. 6 minus 1, that's 5, no? So, yung QRS natin is negative 5. So, compute natin. 90 times 5. That's 450. No? Negative 450. Okay? And then, tignan natin dito sa lead 1. Bilangin natin to. Ilan to? So, this is around, ito 9, no? Parang 9 to. So, that's 450 divided by 9 plus 5, no? Dapat pag nasa baba, absolute values na kasi sila. So, 9 plus 5 is 14. So, negative 450 divided by 14 is negative 32. So, ano ba ang negative 32? Pasok ba yun sa normal axis or do you think that's left axis deviation? Okay. So, that's actually, let's check the next slide. Okay, so it's actually left axis deviation. Kasi ang cutoff natin dito is negative 30. So, nandito na siya. Okay? So, this is what I'm telling you. Sometimes, mukha siyang grossly lad na lad talaga kasi up, down. Pero when you compute, hindi pala siya talaga sobrang LAD, no? Pasok pa din, but may mga instances wherein when you do compute, dito siya pumapasok, oh, sa 28, 25, 20, ganun. So, it's still under normal. Okay? So, if you do get a computation na slightly different, that's okay. Kung slightly different by one box, okay lang yun because may variability talaga. Okay? So, look at the ECGs closely na lang. Ako, nag-eyeball lang din ako from my computer screen. So, the next step would be to measure the intervals. So, you have the PR interval. The normal value is around 3 to 5 small boxes. So, that's around 0.12 to 0.20. For the QRS duration, the normal value would be around less than 3 small boxes. So, it should be less than 0.12. And then QT interval, and we have to correct for the QT interval. Okay? So, but for the purposes of this lecture, we will not go through that. Suffice to know, you know how to count for the actual QT, and then there are also apps online which you can use to compute for the corrected QT. But important to note that the information that you need to be able to correct for the QT interval would be the heart rate, okay, or the distance from the R to R. Practice tayo, PR interval. So let's look at the third QRS complex over here. So you compute from the P to the R, no? So ilan yon? So this is around 1, 2, 3, 4. So that's around 0.16. Pasok sa normal? Yes. Sabi kasi natin around 3 to 5 small boxes. But more than that, that's already first degree AV block, no? Kung example, ang PR interval natin 0.24, 0.28. Okay? For the QRS duration, this one, very narrow lang siya, around 0.04 lang to, no? So normal. QT interval, compute natin from the start of the QRS complex all the way hanggang dun sa end ng T-wave natin. So that's around 4 plus 5. So this is ilan? 9 boxes, no? And 9 boxes times 0.04, that's 0.36. Okay? And I told you, kailangan lang natin siyang i-correct para mas accurate tayo. Okay? So the next thing that we're going to do is to check for chamber enlargement. Okay, so there are a lot of different criteria, but for me, no, i-highlight ko lang yung mas important ones, the ones that are, more commonly used clinically, because hindi naman natin laging ginagamit lahat ng different sets of criteria. So for example, for left atrial abnormality or left atrial enlargement, so usually you want to look at the P-wave duration, no? So if it's more than around 3 boxes, that would be indicative of LAA. For RAA naman, it's not the length, so to speak, kumbaga yung height siya, no? So if you have a tall and upright P wave, that's more than 2.5 boxes, so more than 2.5, so that would be indicative of right atrial enlargement or right atrial abnormality. For LVH, no, kung hindi nyo maalala to at the very least yung LVH, do remember this because it's one of the more common chamber enlargements that we encounter. So we have 2 different sets of criteria. You have the Sokolow-Lyon and the Cornell, no? So si Sokolow-Lyon, we get the S in V1, and then you add it with the R in V5 or V6. If it's more than 3.5 millivolts or 35 millimeters, so that would be indicative of left ventricular hypertrophy. Okay, so this one, ito yung mas ginagamit nating criteria. Sa baba, no, meron ding Cornell na criteria. We make use of the S in V3 plus the R in AVL. And this one will be different yung cutoff if we're dealing with males and females. So you have a higher cutoff for males, so that's more than 28. And for women, that's more than 20. Okay, so again, that's S in V3 plus the R in AVL. So later on, I'll show you how to compute for that. For the RVH, medyo marami, no? Basta basically, if you have a tall R in V1, no, so that would be suggestive of RVH. That's one of the more common ones. Okay, so pati yung RS ratio sa V1 if it's more than 1 because usually you expect na sa V1, punggok lang si R. No? And then as you go along, V1, V2, V3, V4, V5, V6, no, tumataas siya. Okay, that's why kung mababa nga yung R sa V1 to V3, no, so we actually call it poor R wave progression. Okay? Pero kung V1 pa lang, ang taas-taas na ni R, no, so pwede pala siyang RVH. Okay, so we have a different criteria for that, no? So depende kung alin yung gagamitin, but there's no need actually to fulfill all of these criteria. But example, you have a right axis deviation that's already highly suggestive of RAA, RVH. So, hanapin niyo yung criteria na to doon if you're able to compute for a right axis deviation. Next, you want to check for is presence of ischemic changes or infarct. So, ST depression and P wave changes, these would be indicative of ischemia. So, if you have a new ST depression of more than 0.5 millimeter or T wave inversion of more than 1 millimeter, and it has to be in 2 contiguous leads, so that could be indicative of ischemia. But bear in mind that different references would actually have different cutoff values. Okay, so sometimes they would have differences in terms of the cutoff when to say it's significant to be considered as ischemia. Okay, but what's important to point out here is that they have to be contiguous, meaning to say they should represent a territory. So say for example, you have T-wave inversion or an ST depression in V1, and then you have another one in V6, and then the rest of the precordial leads are okay, then that's likely non-specific. So it could be just non-specific, not necessarily a significant finding. Okay? So later, we will look at the leads that are considered to be contiguous. And then for ST elevation, no, so if you have ST segment elevation at the J point in at least 2 contiguous leads with the following cutoffs, so at least more than 1 in all leads except for V2 and V3. So that's already significant. You might want to consider an infarct in this case. Okay? But bear in mind, V2 and V3 would have a different cutoff. So a lot of people get confused here kasi makikita nila ECG, ang taas-taas sa V2, ang taas-taas sa V3, so isipin na agad nila, uy, STEMI. But remember, for V2 and V3, we have a different cutoff. So ano nga yung cutoff natin? So it has to depend on the age, and it will also depend on the sex, no? So kung men, more than 40, so medyo mataas siya, no? More than 2 millimeters. Kapag men less than 40, it's more than 2.5 millimeters. So women slightly lower, so you have more than 1.5 millimeters. So again, mas mataas siya than the usual na cutoff natin for the other leads. So again, how do we say they are contiguous? Okay, so if you have V1 to V4, this would represent anteroseptal. If you have V1 to V2, T-wave inversions, ST depressions, or ST elevation, so that would represent septal. You have V5, V6, that's lateral. High lateral would be 1 and AVL. Inferior leads, you have 2, 3 AVF. And posterior leads are not routinely done, so it has to be requested. No, if you're considering or if you're thinking of a posterior infarct, so you request for additional leads, V7, 8, and 9. And for the RV, you also have to request for right-sided chest leads. So this is actually a better or a more visual representation of the contiguous leads that I was telling you about. So for example, again, ulit, no? V1, V2, this is septal. Pag nasama natin V1 all the way to V4, it could be an anteroseptal ischemia or infarct. If it's V5, V6, this is lateral, this side. Kung 1 AVL naman, so that's high lateral. 2, 3 AVF, you have inferior. Okay? Sige. Okay, so we have an ECG tracing over here, and I want you to take this opportunity to practice. So I'll give you a few seconds. Check for the rate, the rhythm, check for the axis, check for ischemic changes, and try to check for presence or absence of hypertrophy. Okay, so if you need a few more minutes, you can pause the video for a while so that you can analyze the ECG strip at your own pace. Okay, so let's try to do it together so that we can practice. First of all, we need to check for the rhythm. So my question is this rhythm a regular one or is it irregular? So simply by eyeballing, you can see that the interval between the R to R, they are all equal, right? So R to R, R to R, R to R, they are all evenly spaced. So this is most likely a regular rhythm. Okay, so if you have a regular rhythm, you can now compute for the rate using the formula that we talked about earlier. Ano nga uli yun? That's 1,500 divided by the number of small squares. So an easy way to do it, again, would be to check for a QRS complex that falls under the line, no? Para hindi nakakalito tignan. So for example, this one. So you have 5, plus 5, so that's already 10. Tapos may isang sumobra doon, no? So that's 11. Okay? So 1,500 divided by 11, get your calculators, that's 136. Okay? So, paano natin masasabi, ano nang interpretation natin doon, no? So, tachycardic siya. Okay? Is there a P wave preceding every QRS? Yes, no? So, it's sinus. So, this is sinus tachycardia. Next step, how about the axis? Sige, shortcut lang tayo. Check for what leads? Check for lead 1 and AVF, correct? So, lead 1 is upright. AVF is upright. So, most likely this is normal axis. But if you want to be sure, you can compute using the formula that I told you earlier. Okay, so you can pause the video for a while. You can try to compute and check normal axis nga ba talaga siya. Okay? Check for the intervals, check for the PR interval, compute for the QRS complex, check for the QT, no, and try to correct for the QTC. Okay, so skip, no? Dun muna tayo sa mas important na part. Is there presence of hypertrophy? Paano nga natin titignan yon? Yung P-wave natin, no? More than 3 small boxes ba siya? Yung height niya, more than 2.5 ba? Hindi. So, most likely, you do not have LAA, you do not have RAA. Meron ba tayong LVH? Saan tayo maghahanap ng LVH? Sokolula yun. So, you check for the S in V1 plus, no, this one, no, the R on V5 or in V6. Pasok ba? Is it more than 35? So, this one roughly is around 15. So, kailangan more than 20, sorry, para more than 35 siya, right? So, by eyeballing, hindi rin siya papasok ng Sokolula yun. Cornell, you check for the S in V3, mababa lang, no? Tsaka the R in AVL, punggok na punggok lang din. So, mukha siyang walang LVH. But, dito tayo nagkakatalo. Look at the ST segment, no? It's elevated in V1, it's elevated in V2, and also in V3. Pero sabi natin, V2, V3 would have different cutoffs, right? The cutoffs will have to depend on the age, and it will also have to depend on the sex. But this one is outright elevated, regardless of the age, regardless of the sex. Bilangin ninyo to. Definitely, that's more than 2.5 already. Your V1, you only need 1 to be able to say that it's significant. So V1 and V2 are definitely elevated. V3 is elevated in isolation because V4 is not. So we say that this is septal wall MI. Okay? So yun siya. So in terms of calling STEMI in an ECG, there are still other factors that you need to look at to be able to determine the age of the possible infarct, but that's not going to be that's not going to be the scope of our discussion for this session. Okay? So how about for other ECG findings, some miscellaneous findings that you might be able to encounter? If you see something like this, bunny ear in the V1, no, and then you have a slurred S in V6, so this one is a right bundle branch block. And if the QRS complex is more than 12, no, more than 3 boxes, that's a complete. If it's less than that, it's an incomplete, RBBB. How about this next one? So, ang lalim nung niya, no? Yung S niya, yung R, wala ka masyado makita. So, when you see something like this, yung ganitong pattern, this one is a left bundle branch block naman. Okay? And between the two, a left bundle branch block would be more significant, no? Especially if it's a new onset LBBB with accompanying chest pain, no? Pwede kasi siyang counterpart ng STEMI. For AF, no, so in atrial fibrillation, the atria does not contract and relax sequentially during each cardiac cycle. Therefore, the atrial systole does not contribute to ventricular filling. Remember, I told you earlier that atrial systole, no, would actually play a role or play a part in the ventricular filling. But it's not a requirement, no? Because passively, the ventricles will fill even if the atria does not contract. So in patients with atrial fibrillation, since you do not have a coordinated and a true atrial contraction, you will not be able to see the P waves in the ECG. Okay? It will just the atria will simply undergo a continuous uncoordinated rippling motion. So again, P waves do not appear on the ECG and are instead replaced by irregular fluctuations in the potential. These are actually called F waves, no? But We seldom actually do refer to them as F waves in the clinics. We can just say may mga fibrillatory waves and you don't see the presence of the P waves. And another very important thing here is that you can see that the R to R intervals are not evenly spaced, no? So it's not a regular rhythm. It's irregular. So bear in mind, patients with AF, you do not use the formula that we discussed earlier. Okay? So the AV node here is activated at intervals that vary, kaya iba-iba siya. No? Yung QRS complexes natin are not regular. Okay? So this is a normal ECG. Pansin nyo pantay-pantay. AFib, hindi siya pantay-pantay. Sometimes you don't always see the fibrillatory waves like this. No? Hindi siya ganito ka-perfect na mukha talaga may fibrillation. Minsan, it could simply be just the absence of the P wave along with an irregular QRS complexes. No? So like in this picture over here, hindi siya talaga obvious na fibrillation but you don't see the P waves and irregular siya. So that's already AF. So this is actually a variant, no, atrial flutter. In atrial flutter, the atrial re-entry loop and the pattern of the AV conduction are more regular. No? So ayan siya, no? So para tayo may tatlong flutter, QRS, tatlong flutter, QRS. But sometimes it could still be variable. So meron tayo atrial flutter din na may variable conduction. Other ECG findings, if you see something like this, matakot ka na, prepare na tayo agad mag-defibrillate. No? So this is ventricular fibrillation. Okay, so in ventricular fibrillation, often associated with loss of consciousness, there's irregular, continuous, uncoordinated twitching of the ventricular muscle fibers. So basically, there's no effective pumping of blood. Wala talaga siyang cardiac output. Okay, kaya patients with VFib, no, we need to defibrillate. Okay, and how do we defibrillate? You give it at 360 joules monophasic or 200 joules if it's biphasic. Okay, so basically code to, no, pag nakakita tayo ng ganitong patient. How about if we see something like this? This one is wide QRS, regular, ano kaya ito? This is ventricular tachycardia. So si VTAC depende, no? Is it pulseless o meron bang pulse? Syempre kung gising siya, tapos stable, no? Hindi naman natin kailangan i-defibrillate. But if it's pulseless VTAC in particular, you also need to defibrillate in the same manner that you do so in ventricular fibrillation. Okay? So now we proceed with the biochemistry part. So in terms of biochemistry of the cardiovascular system, there isn't really a lot of specific biochemical pathways that only exist for the heart. But here, we would like to emphasize some peculiar aspects of the metabolism. So for the metabolic profile of the heart muscles, in contrast to the skeletal muscles, they only function under aerobic conditions. And there are virtually no glycogen reserves in the heart muscles. Interesting to note that the fuel of choice isn't really glucose. Right? Because we would actually expect na yung glucose palagi yung fuel of choice. But in this case, it's actually the fatty acids. And the least preferred source of fuel would be the glucose. Why? Because yung glucose tends to be not reliable, no? So you can have variable levels of sugar in the blood, right? But yung fatty acid, it's actually present in a more constant or a more regular supply. So parang it actually makes sense, no, that the heart would prefer fatty acids over glucose, right? So other than that, you have ketone bodies and lactate that are also used by the heart under certain situations. So right now, let's try to take a look at some of the commonly used cardiovascular drugs. And let's try to correlate it with the biochemical basis for its use. So say for example, statins. Statins are among the most commonly used drugs in order to lower cholesterol, LDL, no? So definitely for a lot of cardiovascular conditions, MI, no, or in dyslipidemia, we give statins. So what's the MOA of your statins? So this will inhibit the HMG-CoA reductase. And what is the significance of this HMG-CoA reductase? No? So let's take a quick look on the pathway involved in cholesterol synthesis. So here you have acetyl-CoA plus acetoacetyl-CoA yielding HMG-CoA. And in the presence of 2-NADPH and MHG-CoA reductase, it will become mevalonate and undergo a series of reactions eventually yielding cholesterol as well as its derivatives, such as the bile salts and the steroid hormones. But in the presence of your HMG-CoA reductase inhibitor, which is basically the statin, this will be inhibited early on in the pathway. So it will not be able to proceed. Okay? And this is very important since HMG-CoA reductase is actually the rate-limiting step. So this is where the statins will come into play. So next you have your bile acid resins. And what's the mechanism of action of the bile acid resins? So they increase the fecal excretion of bile salts. Remember in the pathway that I showed you earlier, part of the derivatives of cholesterol would be the production of bile acids, right? So you do know, however, that a huge chunk of these bile salts get reabsorbed. So this is actually part of the enterohepatic circulation. We try to recycle, right? At which segment again of the intestine do they get absorbed? Over here, no? So in the ileum. Okay, so nare-reabsorb tong mga bile salts na, sa ileum. Some of them get reabsorbed, but some of them, around 5%, get excreted in the feces. But if you take bile acid resins, no, they will bind to it and it will inhibit reabsorption in the ileum. Therefore, more of it gets excreted. So that's one way of lowering down the cholesterol. So next you have niacin. Niacin would activate LPL, which is lipoprotein lipase, and reduces hepatic production of VLDL and reduces catabolism of HDL. So if it's able to act on the LPL and reduce hepatic production of VLDL, what would be the expected effect on the lipid level? So you know that the VLDL would be carrying triglycerides, right? It's actually one of the main carriers of endogenous triglycerides. So you can see here in the percentage count that the effect is more of a decrease in the triglyceride level, no? So it's more than a decrease of 20 to 50%. In the same manner for fibrates, this one antagonizes the PPAR alpha, causing an increase in LPL activity. Lipoprotein lipase again. Now remember, LPL is an extracellular enzyme on the vascular endothelial surface that degrades circulating triglycerides. So again, the effect of fibrates you would expect will be more for the triglycerides as well. So in this table, you can see that the decrease is 20 to 50% for triglycerides. So here in this table, I would like to present to you the different lipid components of the lipoproteins. So for instance, in chylomicrons, it's composed of around 80 to 95% triglycerides. And for VLDL, this is composed of around 55 to 80% triglycerides. So these two lipoproteins are very triglyceride rich. But the key difference here is that for chylomicrons, they deliver dietary lipids, whereas for VLDL, they would carry or deliver endogenous lipids. So when we are talking about exogenous triglycerides, this would be carried by your chylomicrons, whereas when we're dealing with endogenous triglycerides, this would be the role of VLDL. So following that line of thought, no? So I'd also like to emphasize that there are several apoproteins that play a major role when it comes to the metabolism of these lipids. So for example, we mentioned earlier LPL, lipoprotein lipase, right? So I'd like to mention that ApoC2 over here is actually the cofactor activator of LPL. On the other hand, just add one number, you have ApoC3. And si ApoC3 naman, inhibitor of LPL. Okay, so they may inhibit hepatic uptake of chylomicrons and VLDL remnants. Other than this, some apoproteins also contribute in the formation or the assembly of the lipoproteins. Say for example, you have ApoB48. ApoB48, you mainly see it in chylomicrons and they play a role in the assembly and secretion of chylomicrons from the small bowel. Whereas say for example, you have ApoB100, this time hindi na chylomicrons, VLDL naman, no, endogenous triglycerides. So it plays a role in VLDL assembly and secretion. Lastly, we have ezetimibe. So the role of the ezetimibe is that it reduces intestinal absorption of free cholesterol from the gut lumen. So obviously, the main action will be to decrease LDL cholesterol. And the way to do it is that it directly inhibits intestinal absorption. So in this figure, you can see the presence of cholesterol in the intestinal lumen. And what ezetimibe does is that it directly blocks the NPC1L1, thereby it is able to inhibit the absorption of cholesterol. So certain glycogen storage diseases would also have cardiac manifestations. So just to quickly review, the glycogen storage diseases would have several types. You have type 1, which is called von Jerks. Type 2 is Pompey's disease. Type 3 is Corey. 4 is Anderson. 5 is your McArdle. 6 is Hers. 7 is Tarui. And then you have 11, which is called Fanconi-Bickel. So among all of them, I'd like to emphasize the glycogen storage disease type 2, which is called Pompe. The way to remember it is Pompe pump. So it has a characteristic cardiac manifestation. No? So you can develop cardiac failure. So let's talk about the ketone bodies. So as I mentioned earlier, the heart is unique in such a way that it has preference to use the fatty acids via beta oxidation. And then to some extent, it's also able to use the ketones. It's also able to use lactate. And the least preferred fuel source would be glucose. So ketone bodies can serve as a fuel source. It's synthesized mainly in the liver mitochondria whenever fatty acid levels are high in the blood. But you know what's unique about the ketone bodies is that the liver cannot use ketone bodies. So siya yung gumawa pero hindi niya nagagamit as a fuel source because the liver would lack the thiotransferase enzyme that is necessary to activate acetoacetate. Okay. So energy here is produced via the oxidation of the ketone bodies. So one acetoacetate will be able to produce 2 acetyl-CoAs, each of which would be able to generate around 10 ATPs through the TCA cycle. So that's around 20 ATPs since you have 2 acetyl-CoAs. On the other hand, if you have 3-hydroxybutyrate oxidation, this would be able to yield an additional 2.5 more ATPs because the oxidation of 3-hydroxybutyrate to acetoacetate will be able to give you an ADH. And you know that you can also generate ATP from that. So in summary, for Fischl, we talked about some basic concepts in hemodynamics. We went through some figures, we went through some formula. And again, I'd like to remind everyone to remember or to try to explore further the relationship rather than memorizing simply the actual formula. For basic electrophysiology, we practiced reading ECGs, we went through the concepts, and we also went through the steps in the cardiac cycle. So for anatomy and histology, we went through the gross anatomy, the cardiac conduction system, the coronaries, as well as some basic histology. And for biochemistry, we just touched a little bit on the metabolism, focus on the lipids, the treatment, as well as the biochemical basis for those treatment modalities. So after this session, I'm really hoping that I was able to help you refresh your minds on some of the basic sciences and the basic concepts, hopefully to be able to prepare you better to appreciate the clinical correlates. Okay, so thank you so much for spending your time with me. Good luck and God bless.